Hello, Renell. Oh, okay, yeah, okay, I gotta let you in. Yeah, hold on, I'll just stay here while I get in. You should be able to get an option of, coming in. Yeah, hold on, promote to, how you doing? Great, great, love to. Okay, you should be in. Okay, okay, yep. Yeah, how you doing? Great, love to. Okay, you should be in. Great. Okay. Good morning. Let me get my, can you hear me okay? Oh, Anil, you're muted.
Mute.
There you
Perfect.
go. There you go. So
And
You're in Jersey now, right?
right, yeah, but actually I'm in New York City. I had to come for we wanted to see some plays and stuff, so I'm in New York right now, which is perfect. I love
Miami is not
Miami background, man.
Miami is not a cultural city.
Well,
It's
it's
mostly,
interesting. A lot of New Yorkers have moved to Miami. I mean, that's why they said the real estate there gone out of control.
yeah. Yeah, a lot of New Yorkers here. A lot of always have been. So it's a nice change from the city, but there's nothing like New York City.
Nothing. Oh, we saw a bunch of plays. We saw Steve Carell last night in Uncle Vanya, and
oh,
we're going.
Steve Carell's doing Broadway.
Yeah, his Broadway debut. So that's kind of interesting. Yeah.
Well, I think that means they're dedicated, right, to the craft when they start doing that.
Yeah, because there's not a lot of money in it, but it's it's a good it's not like doing a, box office movie. Yeah.
Yeah, it's like a conference, doing a regular conference.
Exactly.
So
You'll give me a share screen, so can I just practice that to
yeah,
make
sure, sure.
sure?
Should go over that right now.
Yunli is a good guy, but John, we need to do. I was going to do one for the World Federation on brain tumors in the fall, and I'm going to get a bunch of sponsors and stuff. So, I mean, it'll be nice if we run it through with you guys, and maybe we can talk about a bunch of things we want to do.
Yeah, I'd love to. I'm changing my approach. Before I would go to societies and to neurosurgeons in different countries. Now I'm going to advertisers directly and saying, you guys have always supported medical education. Why don't you come to this country and support it? So that I'm trying that approach. So,
I think that's a
uh,
great approach, and I can help you with that. I think we can set up a bunch of webinars that we can do on brain tumors and stuff with the World Federation. I should send you, and I don't know if I sent you the announcement. I just became editor of the WFNS
oh
Journal.
yeah, I put it on the website. Yeah, it was big
I think
news.
that's good news because it kind of gives you a voice to do stuff. Yeah.
Yeah, it establishes immediate credibility. And the sponsor of this site is the Chinese Neurosurgical Journal. I mean,
Oh, wow.
they're the sponsors of it. So I'm
What
sure
is the name of this guy? Buju, the guy who Bujai? What's the name of
oh,
him?
Benzu,
Binju, yeah.
Benzu. He's a very notable cerebral bypass
Oh, he's done
neurosurgeon.
11,000, more than anybody else in the room.
Yeah,
Can you
he
pronounce
does
his name
all
again? Binju.
Benzu, right? He's off the
Well, Ying
charts.
Mao is my continental editor from Asia, so I will
Oh,
announce
okay,
now.
okay. Maybe they know each
Oh,
other.
he works for him. Binju
Oh,
works
okay.
for Ying Mao. Ying Mao is
Oh,
probably the biggest name in China.
oh, okay.
Uh,
Hello,
but let's
Wan
do
Lee.
one
Are
on
you there?
spine. just want to do one on brain tumors. I just want to see how my share screen works. Yeah, let me just see if that works.
Well, Sri, Wanli, good morning.
Yeah, Good morning, John.
Hey,
Good
Yunli,
morning,
how are
Amanda.
you?
Yeah, yeah, good. So nice to meet you again,
Good,
Dr.
how are
Amanda.
you?
Yeah,
Ni
yeah,
hao.
yeah. I heard you talk about Bing Shui and Yin Mao. Actually they are, as you know, they are work in same hospital. Actually, Yin Mao now is the president of their hospital, also the president elect of our Chinese Neurosurgical Society.
Oh, that's
Yeah.
so good. That really is. So the World Federation Journal is now the voice of 40,000 neurosurgeons and we wanted to make sure it's not Eurocentric or Americocentric. We wanted to make it Asia-centric and Africa-centric because that's the future. So
Thank you. Yeah.
you are on the editorial, I think you're on the editorial board. We put you on, right?
Yeah. You send me the message. Also, I think you already contacted Dr. Tang Jie, right? Jie.
Yeah.
He moved to Shanwu Hospital. Both of
Oh,
us
really? How's your
left
wife
to
doing?
same
Where's your
hospital.
wife now? She's still in San Francisco?
Oh yes. Yeah.
You must tell her I said hello.
Okay, sure. We will find chance to meet you again, maybe.
No, we must meet. How's everybody else doing in Tiantan? Everybody do good?
Yeah, okay, yes. Professor Ji Dong Zhao. He's already almost 80, but he's still born.
Wow.
He
Yeah, you
born
brought him
in
to Louisiana when
19.
I was in Louisiana.
Yeah, I think
Yeah.
his son still in Houston.
Well,
Sri, are you there?
hello to everybody.
Mm.
And
Yeah.
Li Zhang, the skull-based
Yes.
surgeon.
Sri, how you
Yes,
doing?
yes. He
Hi.
he just
Just 1 minute.
retired, but still working. Yeah, he retired from the vice president of Tiantan Hospital, but he's still active, very active in neurosurgical societies.
Is there a mandatory retirement in China or not really by age?
There is in
Yeah,
Finland.
that's still 60. After 60, you cannot be the like a chairman president, but you still can be a doctor, professor.
That means I would not be working. I'm 65.
Oh, wow. Anil, I'd like to introduce you to Sri Yi. She's a neurosurgeon from Myanmar. She's currently in Japan now, and she'll be introducing you. Okay.
Excellent.
Sri, okay, you're going to introduce Anil.
Yes.
Okay.
Okay.
And then Wan Li will introduce the second speaker when the time comes.
Sure.
Okay.
Yeah. Okay. No
San
problem.
Francisco. I didn't know your wife was in San Francisco.
I remember I told about that. Yeah.
Oh, I'm sorry. I missed
How
that.
That's okay.
many children do you have now?
Oh, still 2 daughters. Yeah.
Oh, wonderful. Well, you must give my warmest regards to your family,
Sure. Thank you. Yeah.
Is Binzu on the road or at a conference? Okay.
I'm not sure, but yeah,
Okay.
I can ask him.
Okay.
Yeah.
No, we can start. And he'll join if he can.
Yes.
Is my slides projecting okay, or?
Yes, it's fine. I had to take you off the screen there just to introduce you.
No.
Good morning. Good morning, Martin. Are you there? From Dubai? Perhaps not.
Yunli, you like the title of my talk?
Sure. Yeah. Excellent. Yeah. Wonderful. great.
I like
Yeah.
guanine. I have a statue of guanine in my house. I like guanine.
Yeah.
I think in neurosurgery, everybody needs guanine.
Yeah, guanine. Actually, there, there's some maybe thousand of Chinese neurosurgeons. They can watch your talk online. Live. Yeah.
Well, it's always
We
good to
have-
bring some more culture into the presentation.
Yeah, wonderful. Yes.
Yeah, I didn't, that's from that's an allusion to like the mythology of what's that book called? The whole school. Where are those allusions to? What part of learning is that? Are those names that you refer to?
Well, guanine is the goddess of compassion. And it's interesting that in every culture, there's a guanine. And I'll talk about that a little bit.
Oh,
But I
okay.
think the reason I said dragons, because we do have a lot of dragons in neurosurgery for skull base. And I
Oh,
think
okay.
sometimes you have to be compassionate and not, you know what I mean? Just the balance, you know. You have to have a lot of gray hair to say that. So I think I'm qualified. Yeah.
Oh, okay. Okay, ready to start?
Yep, ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have the pleasure today of having Anil Nanda from New Jersey, and we'll start off by introducing Sri Yi. She's a neurosurgical resident from Myanmar, currently in Japan, I think doing research. And she's going to introduce Anil. Good morning, Sri.
Thank you for your introductions. And now I would like to introduce Professor Anil Nanda, and the professor from the Department of Neurosurgery from the New Jersey Medical School, and the director and global neurosurgery outreach. And now the currently editor-in-chief of the World Federation Neurosurgery Journals and the vice president of the American Academy of Neurons. Professor, could you please share your presentation?
Thank you.
Thank
Stu.
you.
I appreciate it. Yeah. Have you got the, are you sharing the screen now or?
Not yet.
No worries. Well, good morning, everybody. You know.
Still not sharing.
Should I try it again? Anything from
Yeah,
my
try
end?
it. Yeah, try it again. Try it again. First click the share screen.
Okay.
Yeah, there it is. Perfect.
Thank you. Well, good morning, everybody. Greetings from the United States. It's a real honor and privilege. And I had a title that I thought would be great for the East in terms of dragons and guanine. You know, dragons are the difficulties we face in neurosurgery, especially in skull base. And I just thought we should go through some of these problems. And I thought guanine is the goddess of, one sec, let me just make sure this is working. Yep, good. So this is, in Chinese mythology, Hua Tuo was a famous doctor, and he performed surgery in the three kingdoms, and he apparently performed a craniotomy on Cao Cao, the kingdom of Wei. And they also say Buddha had a personal physician who performed a brain tumor. I think the history of neurosurgery in China dates back to several centuries. And this is in the Shandong province when they actually did craniotomies on the Dawenko people, that these trephinations were performed almost 5,000 years ago. So that's a great history, a rich tradition that we should all be grateful for. This is Emperor Qinlong, a legendary emperor of China, and this is a painting by Castiglione. And the reason I put this is many years ago, I operated on a patient called Castiglione, who was in Louisiana, and he had a big AVM, and I took it out. And I was going to China right after that, and I said, you know, we're all connected. This was Castiglione's great-great-grandfather from Italy, went to China, painted Qin Long. I operated on him. So we're all together. But I love his royal seal, which said, respect heaven and follow the ancestors. And I think that's a great thing to follow. So now when you look at Guanyin, people say, why did you pick this title? And I think the reason I did it is Guanyin is the goddess of compassion. And if you see that, it's present in every culture, whether in Japan, Thailand, Korea, Vietnam. And dragons are the difficulties we face when we do skull-base surgery, rupture, complications. But yet we must be compassionate. And I think that decision-making process in skull-base is extremely important. And it's something we all work for. So skull-base surgery, I was young when I got involved. It was like a no man's land. And it's really a multidisciplinary approach between vascular surgeons and ENT, interventionalists, radiologists. And, I think the anatomical approaches are so many, orbital-zygomatic, endoscopic, endovascular. So there's more and more approaches. But I think what I was trying to do with this is I've had a vast experience of over 6,000 craniotomies and close to 2,000 vascular and skull-base cases. So I wanted to sort of distill the wisdom that I've learned from all this and kind of present it for you. When you have as many gray hairs as I do, I think it gives you a little bit of experience and it says, well, maybe there's things we can all learn from. So the one thing I want to emphasize to the younger members of the audience, that anatomy is the religion that neurosurgeons follow. If you can pray in the cathedral of anatomy, you will be a very good surgeon. So knowing your anatomy is something that you cannot underestimate, you cannot compromise. And I always tell the residents and the fellows, go to the lab, dissect, learn some more, because the anatomy is key. And I think Rotan did a great service to our specialty by showing us all the wonderful things that we need from an anatomical point of view. And here's a beautiful dissection of his showing the petroclival region, which I will be talking about with petroclival meningiomas. You can see, the trigeminal nerve, cranial nerve 2, 3, that these are important things we need to learn. So what I'm going to take you on is a quick voyage, a journey from the anterior cranial base to the middle cranial base to the posterior cranial base. And then we'll take a little diversion into vascular surgery because contrary to things, I still think there's a role for clipping in some cases. And this is my experience with, close to now probably over 1,000 skull-base tumors, maybe 2,000 aneurysms and skull-base. And so we'll start with the anterior cranial base. The anterior cranial base is, close to 180 patients now that we resected, largely in women, and some of these are really large. So you can see this big cranial base tumor, and these are some of the symptoms they presented with. And my big thing with anterior case meningioma, I do not like to go bifrontal. I've had very good experience coming from the side. I feel you don't hurt the opposite frontal lobe that much. You can disconnect it easily. And here you can see we published this series to show that changes, T2 signal changes in patients where we did bilateral was significant. Now, we didn't follow it up with cognitive testing, which is something that would be good to do. To show that it does make a difference, but I think this is something that's very important, yeah. And these are large olfactory groove meningiomas. I'll give you an example. This is a lady with a 9-centimeter tumor. She had gotten divorced. She was not getting along with her family. And I'll play this videotape here. So you can see we are resecting this tumor. I'll move this along in the interest of time. And you can see it's a very vascular, calcified tumor. And sometimes I tell people, the most important thing in these tumors is that you want to make sure you devascularize it from the anterior cerebral artery. And that's the part you have to be very careful with. Here you can see the carotid, and we're coming up to the anterior cerebral area. And that's where the perforate is. Here you can see the bifurcation, internal carotid, MCA, chiasm there. And this is where you have to be very careful because any small perforator, there are times in microsurgery where you go fast and there are times you really slow down. It's like when you're in the acoustic, you're taking out the facial nerve, you're taking out near the facial nerve, you have to slow down. So here I'll show you this the last part here, you can see the vessels. We're taking it off the vessels completely. Here's the A1, nice and very well skeletalized. So this was about a 10-centimeter lesion, very careful, you can see. Last part we're removing. And we get a gross total resection on her. And here you can see internal carotid, ACA, coptic chiasm with a gross. And there's the lamina terminalis, which I always open the lamina terminalis. So you can see here, we're opening the lamina terminalis. And the last part that we are removing here. And you can see her, this is on post-op day 3. She did very well with no deficits, and we got lucky here. So another case, large tumor. And again, you could say, why didn't you go bilaterally on this? I just went from one side. I divided the forks, took out the rest. And here you can see the picture there with a complete resection. And he lost 50 pounds after surgery. So I said, it's like a gastric stapling. Brain skull-base surgery, you lose a lot of weight. It's good for you. So here you can see him doing very well. Another patient here with a large anterior cranial base meningioma. This patient was hospitalized for dementia. And, nobody checked a scan on her. They did a scan. We took the whole thing out. And she did really well. She went back to live with her family and cognitively did well. Another example, fibrous meningioma that we went unilaterally with a good resection. So the most important thing is the visual outcome, okay? Because especially if you come to for the tuberculum cellae meningiomas, we showed that we had improvement in about a third of the cases where we peeled it off the optic nerve. We published this and we had visual dysfunction before. And here, but see, something like this, you can't take off endoscopically because it goes lateral. So here I can show you, we did a terional, orbitozygomatic, and in the interest of time, I will advance the video. And here you can see, this is the last part. Again, you can see the anterior cerebral. We're peeling it off the anterior cerebral there, very carefully dissecting it off. And I don't like to touch the optic nerve or anything. It's all a no-touch technique. There's the carotid artery here. And this is the last part here, completely peeled off, internal carotid, and you'll see the chiasm in a minute. There you see the optic nerve. And this patient's, the vision actually improved, yeah. So there you see the optic nerve, no touch on the optic nerve. I don't want to affect the vascular supply. The bifurcation looks really good. And here's some flow seal on that. I do ICG on these cases, and he did very well. So what about CSF leak? CSF leak, we had 3 CSF leaks out of 150. One required surgery, one endovascular. So it's a very low rate. And when you look at endoscopic, you need to make sure you can compare that, Now we move to the cavernous sinus, okay? So from anterior cranial base to cavernous sinus. Again, the anatomy is very important. This is Parkinson's triangle. You can see the 4th cranial nerve, 3rd cranial nerve, internal carotid artery, pituitary vessel there. Now, skull base, when I was a fellow at Pittsburgh, we were very aggressive with cavernous sinus meningioma. We took it out, grafted the carotid artery. But then all these papers came out that said, you know what, when you operate on these, the meningiomas have got into the cranial nerves. So you really can't get a complete resection unless you take all the nerves, which has a huge morbidity. So this was our paper that we published on the cover of Journal Neurosurgery on cavernous sinus meningiomas. And this was our series now of about 90 patients with cavernous sinus meningiomas. Sometimes cavernous sinus meningiomas come out easily. Soft tumor, here's one that I did. And you can see it was a soft tumor and the whole thing came out. But it doesn't happen all the time. So you can see this is a split. We split the fissure. We're removing the tumor there. And a complete resection was done there. And you can look at the MRI, it looks great. But that doesn't happen all the time. So you can see here, this is a tumor, it's unresectable. Even if you said, well, we'll take out the carotid, we'll graft it, it goes on to the other side. So in these cases, we do a subtotal resection and we do gamma knife. So when you look at tumor control with 5-year follow-up, surgery alone versus surgery plus Gamma knife, the recurrence rate was big difference, okay? If you do Gamma knife up front, our recurrence rate was much lower. If you do it later, it was a much higher recurrence rate. This was Karolinska also published the same thing. This shows the hazard function, increased risk of recurrence in the surgery only versus surgery plus Gamma knife. So this was clear cut to us. If you had residual tumor, you should Gamma knife it. And this shows all the recurrences managed by radiotherapy alone, managed by surgery. So I'm a big believer that if you have a small residual with skull base, you're better off doing a radical, you're better off doing radiosurgery with good control. And the other thing I would mention is that, you don't get a complete resection. If you want good clinical results, you don't want to be that aggressive that you destroy the patient's eyes and stuff. So here, our resection rate was only 41%. It was not that high. So that's just something to remember. I want to move now to acoustic neuromas. So that I use this as a teaching case always. This was an acoustic attempted in another hospital, and they got a lot of bleeding, and they sent me the patient. And I think all the residents here, if you notice, they didn't take the bone off here. You see how they made a small opening? Whenever you're doing these posterior fossa surgeries and you're going retromastoid, make sure you take bone off all the way to the sinus, okay? You have to go all the way to the sigmoid sinus. That's what you want. And this is what we did. She did great. And then again, facial nerve, small tumors, I think you can get a good resection. But I feel larger tumors, even though you save on the facial nerve, sometimes you will get functional inability. This is a girl that was going to get married in 6 months. I had a lot of pressure, but here her nerve is fine. She had a good smile. She did great. Another patient like that, where I left a little bit of residual on the facial nerve, and she did really well, long-term follow-up. And the natural history of vestibular schwannoma, there was data from Denmark that said, these things don't grow that much. And now NYU Konzialko's data show that there is growth if you do 3D measurements. So it's something to think about how we do that. And again, the natural history of meningiomas is slow growth. But if there's edema, if the size is larger, then I think we need to be more careful. This is our acoustic that I wanted to show this. The vascular acoustic. And here we're taking off the last part there. I like here, you can see the facial nerve. There's a large acoustic with normal facial nerve function. And you can see very gentle dissection on the facial nerve. See that? This is the whole case in an acoustic. The rest of the stuff we can take off. Trigeminal nerve all goes quick. This is where I really slow down. You can see I'm peeling it off the facial nerve with extreme caution. You know what I mean? You don't want to go fast or anything like that. Yeah. Here, slow and steady, get it off the facial. And here you can see how it gets splayed out. Sorry. And you can see completely cleared out there. So we're able to get a good resection here. Again, anatomy is very important about partial labyrinthectomy, your exposure. So this is the case that I really lose a lot of sleep. This is my petroclival meningioma series, and how they present with headaches and difficulty. This is a small tumor. This was a nurse. She didn't want to get Gamma knife, even though this is a size for Gamma knife. She had an excellent resection. Here's a really small tumor. Patient wanted it out. We resected that. And here's somebody with a real giant petroclival meningioma. And here, I'll show you the videotape on this. And this is painstaking. If it's soft, it comes out, it's easy. But if it's firm, here it is, we're peeling it off. That's the trigeminal nerve, last part here, peeling more and more off. And we were able to get a very good resection on this. We had a small residual that we went ahead and Gamma knifed, yeah. Again, this is a schwannoma, trigeminal schwannoma, same thing. the petrous bone tumor tentorium. And this is soft. It was an easier thing. Now, if the trigeminal schwannoma is mainly in anterior, then I come extradurally, anteriorly. But this was largely in the posterior fossa. So we went posteriorly, and we got a really good resection. Again, I like to emphasize you want to stay in the arachnoid plane. You don't want to, this is the inferior pole mobilization. And we were able to get a nice resection of this, yeah. There was some residual, look at that, right here. This whole posterior fossa was removed. I gamma knifed this. He's got very good control with no problem. So petroclival meningioma, the natural history is, there's growth in 3 to 4, 3/4 of these patients. But I think you have to really judge your judgment. This is where guanine comes in. You have to be very compassionate. If this was your mother or your grandmother, what would you do? And I think it's important to say that in an older person that's not symptomatic, my feeling is let's just watch them. And I'll show you some cases like that. Now, what about this? This is a young girl, okay? And she's got this tumor symptomatic, which I thought was a petroclival tentorial meningioma. And it really turned out to be a trochlear nerve schwannoma. But this is a very delicate surgery. I used to do petrosectomies here. I went purely retromastoid. And you can see there's the 7th and 8th cranial nerve. And we peel this off. And you'll see the 4th cranial nerve. Here's the 4th cranial nerve. You can see that beautifully right in the center. And you can see how the nerve is stretched out. And we got this off the nerve completely. And she did not have a 4th nerve cranial palsy here. So we got a complete resection on this, but you want to be very careful with your exposure and the sensitivity with which you peel this off, So this is Lao Tzu. It says see simplicity in the complicated and achieve greatness in little things. So I think you have to be very careful on the way you indicate and do the surgery. This is the post-op MRI, complete resection. She's now 5 years out, no tumor. I wish all my cases did great. This is a physician that I operated on petroclival meningioma, left resection, and he had issues. So it's very important when you don't want to get carried away. You can have a beautiful post-op MRI, but if your patient's not awake, this is where guanine comes in. The dragon is you want to get everything out, you want a good post-op MRI. The compassion is what is the quality of life? You know what I mean? So you have to have that balance. And this is Achilles in the Iliad, when he says, I want glory, and you have to decide between Kleos and Nostos. Nostos is a safe journey home, Kleos is glory. Sometimes we want the glory. We want a great post-op MRI, but we are losing our compassion a little bit because quality of life is affected. I'm going to switch gears a little bit to vascular issues now. I've clipped over 1,000 aneurysms, but I'm a dinosaur. I call myself a cliposaurus as opposed to a coilosaurus. That's the dinosaur that coils aneurysms. So these are about almost 2,000 vascular cases that I've done with AVMs and gamma knife and aneurysms. And I'll show you, this is a giant aneurysm. Today, this would not be clipped at all. This would just get a coil and it would fix it. A stent coil would fix it. But I think it's important to know this. I was talking to my friend in Pakistan, Asif Bashir, and he says a lot of the patients cannot afford a stent coil. So you must know how to clip this because if it fails, that's a style that you should know. So here you can see this is the falciform ligament, carotid artery. Here we put clips across the neck of the aneurysm. The carotid is here. Optic nerve is right there. And we were able to clip this nicely. And the mass effect went. We published our article on ophthalmic artery aneurysm, and clipping at least 15 to 20% had better vision. And she did really well. This is the post-op angiogram. And we published our series on ophthalmic artery aneurysms, and there was visual improvement, you know. So I think it's important to show good outcome in this, yeah. What about basilar tip aneurysms? Okay, so here you can see this is some in ACOM, but they couldn't coil this this posterior superior cerebellar aneurysm. So this one I did, I clipped. You can see here. We split the fissure. It's the optic nerve. Wide clipping of the Sylvian fissure. And this is, you'll go down now, you will see the superior cerebellar. I mean, it's the basilar tip right there. We're taking the blood off. Here you can see the PCA and the PCOM. And now we'll see the neck of the aneurysm right there. There's the neck of the aneurysm. You can see the basilar artery, PCA, and we put a small clip right there. But I think the morbidity on these cases is lesser because there's no perforator. So you can see we put a little clip right there, straight clip. This used to be my favorite, my favorite case, basilar tip aneurysms. But now it's an endovascular disease. So you can see here she did very well with no problems. It's a post-op angiogram. We published our basilar tip series, and like I said, this is not an operative case anymore, but you should know how to do it. You know, how do you split the fissure? I spent some time with Sugita in Japan, and he really helped me get good at this, to split the fissure. I was young attending at that time. Now, other aneurysms, this will be published in my book. You can see a proximal basilar tip aneurysm here that we with the far lateral approach. And then multiple aneurysms, somebody with 7 aneurysms here, that we went ahead and clipped them. Coiling this would have been difficult. I'll rush through this in the interest of time. Here you can see 1, 2, 3 aneurysms right there. And we were able to clip these beautifully with a good outcome. What about cavanomas? This is a young girl that had a brainstem cavanoma, and here your skull-based approaches are very good. You can see she was hemiplegic with a big blood clot. This is her post-op. And the most important thing here is the stealth. I think that makes a big difference. Second, I'm trying to get this to work. So here the stealth is really important. If you have some frameless system, because you don't want to go digging in the brainstem. So there's the trigeminal nerve right there. Made a small opening between the trigeminal nerve and the 7th and 8th cranial nerve. We're now going directly into the brainstem, making an opening there. And these are the anxiety moments when you're not sure if you're in the right place. You're digging into the brainstem, and the moment you see this, you say, you know, we are blessed. So here it is. The whole lesion came out, and a very good outcome there. Let me just move this. So complications is a big part of our business, and we need to avoid them. I think that's something I like to talk about. I wrote a book, Complications in Neurosurgery. Actually, this was just translated into Chinese. So I think this talks a lot about what things go wrong. I talked about my petroclival meningiomas, and I think I want to end with the foramen magnum area. You can see in the foramen magnum here, this is Halapu, the first reported case of a foramen magnum meningioma, right at the base of the skull. And here's the anatomical thing of looking at the vertebral artery. We used to transpose the vertebral artery on foramen magnum meningiomas. We don't do that anymore. I think you can just drill it well. And here's someone with pre-op, post-op. We published this, that you didn't need to drill out the occipital area. But I think when you look at all meningiomas, I looked at my entire series of meningiomas and Simpson grading. And this has been attacked a lot, but I think we still believe in the Simpson grading. I think it makes a difference, and it's an important paper here. It's told you a number of cases that we did. But again, I come back to complications. I think CSF leaks, if anybody tells you in skull-based surgery, there's no complications, no. Complications are the dragons of skull-based surgery. They bite you from different angles, and you have to be vigilant. And I would be lying if I told you that all my cases had no complications. And I think it's very important for the younger people to know that you will get complications but you must learn how to handle it. So here's somebody, I did a very nice Sylvian Fisher meningioma. I took this out. I'll show you, I thought I did a good job. He did well. Here you can see the entire internal carotid artery. Every piece was removed. I did an ICG that showed the carotid was completely open. And I was very pleased with this. The patient did well for 72 hours. The daughter was a nurse, and you can see it looked beautiful. Everything was fine. He was intact. And this is what happened. 3 days later, his internal carotid, the middle cerebral artery thrombosed. He had a stroke. He recovered. But, this thing can happen. So this is René Lariche, who was a famous French surgeon. He says every surgeon carries about him a little cemetery in which he goes from time to time, a cemetery of bitterness and regret, of which he seeks the reason for certain of his failures. So we all have cemeteries, no matter, we all live in glass houses. We have mistakes, things go wrong. And it's just not in open neurosurgery. It's also in radiosurgery. This is in Pittsburgh, somebody gave me this slide of a community surgeon that this is a acoustic, they gamma knifed it, and you can see they made a hole in the peduncle. So, things can go wrong on multiple fronts. This was in the New York Times. They had a new system for giving radiosurgery for acoustic neuroma, and they gave 10 times the radiation. And 6 people died, horrible deaths, because your brainstem was burned completely. And the patients all died. All of them were treated for trigeminal neuralgia and had a terrible outcome. So sometimes these things happen. You have to be really vigilant against it. But again, I think one of the things that I like to emphasize is guanine. You must have compassion in these cases. This is a beautiful lady with a large calcified petroclival meningioma. When I was younger, I would have said, oh, we'll take this out, okay? I would have done a big approach on it, taken it out. No, this time she had hydrocephalus. This is a calcified meningioma. I didn't think this was going to grow. So I put a shunt in her. She's now 8 years out with no problem at all. So I think that's where you have to be compassionate, that your judgment should not be, if I see a tumor, I'm going to take it out. And I think the important thing is that's where guanine comes in, that you have to be compassionate, make the right decision. This is from the famous Hippocrates, who said, primum non nocere, first do no harm. And this is an acoustic that I've followed for 10 years. It never grew, okay? It's a 3-centimeter acoustic. You say, well, why didn't you gamma knife it? She didn't want anything done. Now, the patient says, I don't want anything done. I'm like, okay, this is what you decide. And you don't want to walk into the thing and say, well, your surgery was unnecessary. So I think that balance is very important. So to sort of summarize, I've had a really blessed career in skull base. This is all my skull base series of meningiomas. I was very fortunate to operate on a wide variety of cases. And I think I like to emphasize to the younger generation that you must write about it. I remember I'd finished 100 aneurysms, and I had a mentor by the name of John McDonald. And, he said, if you don't write about it, nobody will ever know. And I took that to heart, so we published our series, I've done 2,500 anterior cervical effusions. I put that out. These are all my papers on skull base over the years that I've sort of diligently recorded and published. And I think that's important. I think one of the take-home messages, if I had to summarize what I'm saying, is technical virtuosity is a very important skill set. You must get good technically. It's very, very important. This is surgery. So getting good technical skills is really important. Knowing your anatomy is very important, and publishing is very important. I think these are three things that go a long way in making you successful. I'm a history buff, and I always like this about the two generals, Zheng Guofan and Ulysses Grant. He says when they finally met, he says, you and I have suppressed the two greatest rebellions known in history. And I think that's a common tie between the American Civil War and the Chinese Civil War. The Chinese Civil War was much more bloodier, but I thought that was an interesting. I'll end with our new WFNS journal. I was going to give this talk on the day of the Chinese New Year. So I know it's a couple of months past, but I still want to wish all of you a great Chinese New Year. This is our new open access journal. It's the voice of over 40,000 neurosurgeons worldwide. We want all of you to get involved. This is the QR code. Please submit your papers. This is going to be open access, so everybody can read your papers, and I think that's the future of journalism in this area. So kind of to summarize skull base, Diogenes was the Greek philosopher, and he said, I'm always looking for the truth. They said, why are you hiding? Why are you always walking out with a lantern? And he said, because I'm always searching for the truth. So I think anterior cranial base meningiomas, it's possible to get a good resection with low morbidity and mortality. Cavernous sinus, petroclival, I think to get subtotal with gamma knife, you're fine. I think it helps vascular neurosurgery. I think Simpson grading is important. And complications tend to be significant and serious, So I think the dragons of skull base are the complications that, you get CSF leaks, you get hemiparesis, you get all kinds of dragons that will attack you. But guanine is compassion. What would you do if this was your family? So if an 80-year-old comes with a petroclival meningioma that's not that symptomatic, I think we need to be compassionate and say, listen, we can just follow you. So I think, again, I would stress to the younger that, you want to be very cautious in your indications. You want to know your anatomy, and you must publish it. So, neurosurgery, to me personally, has been a great blessing. You could argue that the dragons of neurosurgery have given me gray hair, but I would also tell you that guanine has been very kind to me. So this is William Wordsworth, the great English poet. He says, and then my heart with pleasure fills and dances with the daffodils. I would tell all of you that you must love neurosurgery like Wordsworth loved daffodils. And this is T.S. Eliot, who said, next year's words await another voice. And I hope one of you in the audience or several of you become experts in what you do and add to the field and enrich our specialty, which is such a great blessing for so many of us. Every time I open the Sylvian fissure, or I split the fissure, or I take out something, I'm like, I can't believe they pay me to do this. This is so much fun. And the beauty of what we do, we should never lose the wonder of what we do. And the last thing I would stress is humility. Je le pensais d'où la galerie. This was the epitaph on his grave. And he was the father of surgery. And what he said beautifully was, this was the epitaph he wanted on his grave. And he said, I did the dressing and God did the healing. And this was Ambrose Paré. And I'll end with a little thing. This is how we're all connected. There's a volleyball player from China. I was taking care of his daughter. She got a full scholarship into NYU and tells her mother, this is the happiest day of my life. And she goes out to go with her friends and has a bad head injury. It's a coma the same night. And, we thought she had a terrible prognosis 3 weeks ago, but, guanine can sometimes intervene. And she's suddenly woken up and showing me 2 fingers. So I think hope springs eternal. We face difficult problems in neurosurgery, but we are blessed to practice a great art. Thank you so much for this opportunity. Shia, I'm really blessed to be here. And I guess I'm open for questions. Yeah.
Okay, very good. Thank you, Doctor. Okay, Shri, are you there? Shri is going to handle the questions. Okay, very good. Okay, any comments or questions? I'm glad to see Martin is here. He's one of the more cultural neurosurgeons in the world. Hello, Martin. I'm sure you have some comments or questions there. Hello, Martin. You're on mute.
Well, hi there. I'm struggling with a new computer here, and
No, you hear
and
you're fine.
it's not working well, you know. So anyhow, so yes, you know, I did my skull base surgery with Fred Gentili, but at the time I was considering actually going to Shreveport. That was where Anil was working and so on. But anyhow, no, I think he ought to emphasize the little technical details. You know, when you look at his surgery, he hardly ever coagulates. He may shrink a tumor a little bit at the surface, but he mostly dissects it off in the arachnoidal plane. And that's really the key of getting things out gently. He's doing a little bit of pulling, a little bit of cutting of a fiber here and there. And that's probably the key of getting these tumors out very nicely. And I like the way he separated the facial nerve from the acoustic surface. Sometimes they're even more spread out, and you have to use the angle of a hook. And he had another instrument there to sort of gently push the nerve off. And yeah, so maybe he wants to comment a little bit on some technical tricks he learned over the years. I'm sorry, the video is not good, and the acoustics is also bad.
No, thank you for your kind comments, Martin. You know, I think, you know, I was a young fellow at Pittsburgh, all right? And I remember Majid Sami doing an acoustic, and I first assisted him. And it was like watching a symphony. There was no wasted motion, you know what I mean? And I think technical virtuosity is something we all aspire for. You don't get it overnight. And I think you're right, if you stay in the arachnoid plane. But I like this concept of acceleration versus deceleration. When it's easy and it's soft, you accelerate. When it's stuck to the facial nerve, you decelerate. And I think that's where master surgery comes in. You know when to slow down and you know when to speed up, because otherwise it's a lot of unnecessary motion. And, you know, this is something I've debated, is this technically we can all get better, but I think sometimes this is an intuitive art. For me, surgery is intuitive. I think you just kind of go. But for some people, it's painting by numbers, you know what I mean? And that's very good too. They have great results. But I would emphasize that staying in the right plane, knowing your anatomy, good exposure, little things that make us go a long way, you know. And I mean, I think an acoustic or a petroclival meningioma is still a very humbling thing. It's not, it's never easy, and you don't want to say, "Oh, this is easy. It's gonna go well," and you don't want to jinx yourself. So I think that humility is also part of the learning process. Yeah.
Right. If I may say, you know, some of the meningiomas, when they're calcified, they're often, they can be stuck down in certain places. And I find that using the micro scissors, because they kind of pinch things, they're often more trouble. And the idea of using even an 11 blade that is kind of guarded by a steri-strip or something, so that it just cuts at the very tip, or some other fancy knife, and using the knife like a paintbrush. Don't push it into the tissue. Just use it to loosen a little bit, loosen the fibers and then try again with, you know. So don't force blunt methods when you need sharp methods. And the micro scissors can often be a source of trouble in such situations. What do you think?
I agree. I think, you know, and everybody has an instrument they love. I like the flat knife, the feather blade, the circular one, especially for acoustics. I think that works really well. I like a 60-degree dissector because I can use that to ferret out tumor a little bit. You know, and I feel the art, like, you know, I'm like a cliposaurus. I'm a dinosaur, okay? Nobody's going to clip 1,000 aneurysms anymore. It's over, you know? It's a different era. But I do think the technical skill sets we acquired with vascular neurosurgery, I mean, you know, Binju has done 11,000 bypasses, you know what I mean? So I think those skill sets are translated into doing good surgery. I mean, even doing an anterior cervical fusion, you learn from it, you know what I mean? And I think it's a sacred art. That's what I like to tell the younger people. The art is something we all worship at, the art of technical virtuosity, you know, that you want to get better at this, and how do you get better? And you know what if somebody said you're unconsciously incompetent, and then you're consciously incompetent, and then you're consciously competent, and then you're unconsciously competent. And we all aspire to become unconsciously competent. Like, okay, this, boom, we got this, you know.
Yeah, right. Very wise comment, actually. Yes, and I also like I like the word peeling, because a lot of these techniques are a matter of peeling things now. And you can even learn in the kitchen how to peel something. So there you go.
And you know, I remember going through a microsurgical course in Vermont, which is where Yasagil learned to do an ECIC bypass. And you know, I think the simple thing of cutting a glove and using a 10-O-Proline to stitch the glove together, it's a technical exercise, and it makes you better. No question, it makes you better. And I think that hand-eye coordination, you know how we tend to say, well, I want to operate. I think there's plenty of ways to become, because that's simulated learning now. And I think all the data showing, if you do simulation, I mean, they're learning how to fly a 747 on a simulator. So there's no reason why we can't get better by simulation as well.
Well, let me share something with you. I was a resident. I'm Swiss, okay? So I was one of the residents there, and it wasn't easy with him. But I spent I spent most of my time in the lab, and I didn't use gloves, but I used rats, and I think that's really what I learned there. But a few more things. But anyway, that was very valuable there. Yes. And nowadays we don't have so much dissection uh, facilities in many parts of the world. We did a course here with dissection for the residents, and let alone to actually do live surgery on rats, or yeah. So yes, that could be valuable if it's available.
I think it's important. And, you know, this is even if you're a resource poor country, you can take an orange under the microscope and try and peel off the cover or separate it. So the technical skill set can be translated and can be used, you know. Again, Yasagil was very interesting. I think you learn from him. You know, Sami, Janetta, these were the legends of neurosurgery, that they pushed out the envelope, and now they're different legends. There's endovascular, there's all this sort of stuff that everybody helps, you know.
Okay. Thank you, Martin. It's good to have you back. We have a question from a neurosurgeon from Afghanistan, Mutawaki Zahir. Dr. Zahir, can you ask the question, or do you want me to? Can't hear from. He says, it's not really a question. This is the difference between meningioma and hygroma.
Well, you know, meningiomas are obviously solid and they're not cystic, whereas hygromas are more fluid. So it's easier to remove those. Sometimes you'll see hygromas as the complication of meningiomas, especially if you take a large one out. And then sometimes you take our large meningiomas and you get hydrocephalus and you have to put a shunt in. So I think those are just some of the issues with hygromas and meningiomas. Yeah.
Okay. Any more comments or questions? Okay, doctor, thank you very much for your time, and we'll be talking soon.
Thank you. Share to all of you. Thank you, guys.
Thank you. Okay, we have the next speaker. I'll let Juan Lee, the Director of Division of cerebral vascular surgery at Beijing Tiantong Hospital. I'll let Wanli introduce the next speaker. Hello, Wanli.
Hi, John. Yeah. Okay. Thank you again for Dr. Nanda. Your wonderful talk. Actually, yeah, you talk about the dragon and the Guanyin. I'm quite interesting, and yeah, you gave some explanation of about the difference between dragon and the Guanyin. I think that's very interesting. Maybe next time we can talk more in detail. Yeah. Okay, so let me introduce the second speaker, Dr. Zixiao Yang. She's a female neurosurgeon from Shanghai Huashan Hospital, also the colleague of Dr. Bing Xu. Yeah. So today she will introduce their experience for the surgery of brainstem carcinoma, and with a kind of a special approach. Yeah. So Dr. Yang, you can start your talk.
Thank you, Professor Zhao, and hello, every professors. I'm Yang Zixiao. Now I will share my screen. Just wait for a minute.
Okay, no hurry.
Okay.
We always wait for tech.
Yeah, it is my honor to share the topic, follow the winner's path to the hidden lesion, a technique trick in brainstem corners malformation surgery. So it is a teamwork. So the corresponding author is Professor Song, and also thanks for the guidance of Professor Zhu and Professor Mao. Oh, just wait a minute. Can you see the screen now?
Yeah, it's still loading. I think you have to try it again. Try to load it again.
Okay. Oh, okay.
Yeah, go off. Oh, okay, it's coming. There it is. Perfect. Perfect.
Yeah, so the brainstem corners malformation is still a challenge for the neurosurgeons. The relationship between cavernous malformation and developmental Wiener's anomaly has been widely recognized by neurosurgeons. The surgical resection is acknowledged as the optimal treatment for brainstem cavernous malformation. So there are several surgical indications. The first is when the brainstem CM reach the pile surface. The second is when the cavernous malformation rebleeded for more than 2 times. The third indication is that even the CM is very deep-seated, but there is a safe entry. It is under the safe entry zones, and we can reach the CM very safely. So there is another indication is that even though the CM is very deep-seated and not very safe, but it's rebleeding for several times, and it is very severe and the patient is unconscious. So the primary goal of the surgery is to prevent further hemorrhage rather than the neurological recovery. The surgical strategy is to balance the hemorrhagic morbidities and the surgery-related morbidities. So there are several surgical tricks to do the surgery safely. So there is the 2 points method. That is, the one point is the center of the CM, and another point is on the pile surface. So we use the 2 point to find the proper approaches, and we also use the neurophysical we also use the monitoring to help to find the important brainstem nucleus beside the CM. Until now, there are several approaches was recognized to reach the CM. For example, to reach the CM in the midbrain, we can use the transorbital zygomatic approach, the SCIT approach, or Poppen approach. For the CM's implants, we use the retrosigmoid approach, or SCIT, and also for the CM's in the medulla, we can use the lateral supracondylar approach. So there are more than 13 safety zones can reach the CM. So the brainstem CM surgery is now can be conducted. But it is also very difficult and still a challenge for the neurosurgeons, because it needs experienced neurosurgeons to find the proper entry point. So we use the two-method safety and the two-points method and the safety entry zone to recognize the proper approach, such as the suboccipital midline approach, or the Poppen approach, or the suboccipital midline approach. So that method is help us to find the proper craniotomy. And after the craniotomy, we reached the brainstem, and we will use a navigation to find the proper point on the pile surface. But the navigation can be misleading, because after the release of the cerebral the cerebrospinal fluid, it can move. So after the craniotomy, we also use the neural monitoring to help us to find the brainstem nucleus near the CM to avoid the injury of the nucleus. So after all these methods, we reached the brainstem surface. And the critical steps during the brainstem cavernous malformation surgery is to localize the lesion precisely to minimize unnecessary dissection during entry into the brainstem. So because the brainstem is very important, and especially for the deep-seated and the small CM, it is very difficult. We want to minimize the injury on the surface. So we analyze the different surface of brainstem. It is our teamwork published on the What Neurosurgery. As shown in the picture, we can see that the surface of the brainstem cavernous, the surface of the brainstem in cavernous malformation can be divided into 6 different types. So we can see in the picture A, B, and C, it is very easy to recognize where the CM is and to find the point. But in the picture D, E, and F, it is difficult to find the CM. So it is the type A. Type A is the superficial brainstem cavernous malformation with blood staining. So we can see the red blood staining of the brain surface. So in this situation, we can easily to reach the cavernous malformation. We can just follow this blood staining. And this is the type B. Type B is a superficial brainstem cavernous malformation with abutting the pile surface. We can just see the mulberry-like CM on the brainstem surface. And in this situation, we can also localize the CM very easily. So the picture C, picture D, and picture E show the deep-seated brainstem coronus malformation under the surface with dark, light, or no hemosiderin staining. The hemosiderin staining is the yellow staining after hemorrhage. So we can see that in picture C, we can still find the CM under the yellow staining, but in picture D and in picture E, it is very difficult to localize, especially when the CM is very deep-seated and the navigation can be changed after craniotomy and CSF releasing. So there is also another type that is the type F. We can see a dilated developmental venous anomaly shown by the white arrow could be observed on the brainstem surface. So in this situation, we found that the venous anomaly can help us to find the CM. So in our previous experiments, one time we accidentally damaged this vein, and we found we can follow this vein to the CM, and also there is no serious hemorrhage during the operation, and no serious cerebral edema after the surgery, and the prognosis of the patient is very well. So in previous study, we always think that this vein should be preserved just like the drainage vein in the AVM, because sometimes it is the drainage vein, and the damage of the drainage vein can lead to the very serious bleeding. But we found that sometimes in the CM in other locations, the venous beside the CM can be the venous malformation. In that situation, this venous have the normal function. So in that time, it should be preserved. But in the brainstem coronus malformation, the venous is the developmental venous anomaly. That is, this venous is not the normal vein with function. So most of the time it can be it could be damaged in the surgery. So this is our hypothesis that the venous this venous anomaly can help us to lead to the CM and help us to do the surgery. But to prove this opinion, so we analyzed our patient's situation. So from 2011 to 2019, totally 74 patients with the BS brainstem coronus malformation do the surgery in our hospital, and in these 74 patients, we found totally there are only 11 patients have the DVA just near the brainstem coronus malformation. So in the operation, first we try to find whether the DVA can lead to the coronus malformation, and we found all the DVA can just lead to the CM. And during the operation, our principle is to preserve the DVA first. But sometimes when we cannot preserve the DVA, we just damage it. So totally, finally, 6 DVA was preserved, and 5 patients the DVA did not preserved. And we found that there is no significant difference of the MRIs and the prognosis of rebleeding or cerebral edema after the surgery before the different groups. So here are 2 examples. The first example is a 36-year-old female with the hemorrhage, with cavernous malformation on the right medulla. So after the craniotomy, the navigation is not very precious. So we just follow the DVA and do the total resection of the medullary CM. During the operation, the DVA was preserved very safety, and but the bleeding of the DVA was released after the surgery. So just shown in the picture E and the picture F, we see that just near the DVA, we find the point to cut the pile surface, and then we find the CM. And during the operation, we try to preserve the DVA, and we can see the DVA. We can follow the DVA to the CM. So the patient was safe, and the MRIs was the same before and after operation, and no rebleeding. This is another example. It is a 35-year-old female with the brainstem cavernous on the points. So we can see there are a yellow staining between the facial nucleus, and we can also see in the picture D and picture E, there is a DVA just near the there is a DVA, and we follow the DVA to try to find the cavernous malformation. During the operation, we preserved the DVA and totally and the CM was totally resected. The prognosis is very well, and the MRS was normal. So this is a conclusion of our experience. Because the brainstem cavernous malformation is relatively rare, and after we divided the brainstem cavernous malformation into 6 types. So the last type, CM with DVA, is relatively is very rare. So there are only 11 cases. So this experience need more experience from other hospitals. So we just want to share our result and for more conclusion. So the first, we think that the brainstem surface DVA can provide useful guidance clues to trace deep-seated brainstem cavernous malformation, especially tiny lesions that are difficult to locate by navigation. The second is the brainstem surface DVA can help localize the deep-seated cavernous malformation without the need for aggressive exploration. The third is it might be safe to follow the Wiener's path to the hidden lesion inside the brainstem. So thank you for your attention. It is a teamwork from Huashan Hospital. So thank you.
Thank you, Dr. Yang, for your nice talk. Yeah, actually, you just tell us that it's kind of a different approach, because I think when we do the surgery to remove the cavernoma from brainstem, I was told we should not touch the vein near the cavernoma. But yeah, according to your introduction, seems it's safe even if we coagulate the vein. And another thing is that we can use the vein as we just follow the vein to find the cavernoma if the navigation system not work. Right?
Yeah, thank you. Yeah, thank you, Professor. Yeah, The first conclusion is that we can use the DVA help us to localize the CM, and the second is our experience is that sometimes if the DVA is not preserved in brainstem CM, but not in the CM in other location, most of the times there is no serious cerebral edema after the surgery, because the weighing on the surface of the brainstem is mostly not the drainage weighing with the normal function, but it is an anomaly.
Okay, yes, I agree.
Thank you.
Okay, thank you. So, are there any other questions or comments, like Dr. Martin Util?
Yeah, Martin, how you doing there? You're still there, right, Martin?
Yes, I am, and I'm still struggling with this computer here. Well,
Okay.
it's a very nice talk, and it brings up a very important point, because there's always been a debate of what you actually do in these difficult locations with the actual cavernoma, the mulberry. But what happens? You see some abnormal tissue, you do a bit of suction and dissection, and somehow they're kind of benign and they come out, and end of story. But I want to ask, if what that is the other issue is, if a cavernoma is very small. I mean, it depends also what is the clinical presentation, but I mean, they get if they're too small, you just simply can't find them. So maybe you better leave them alone until they bleed next time. And then they create some more hemosiderin, and then, or maybe a bigger cavity. And so then you can resect them properly. So I don't know what is the current thinking in Shanghai at the moment, or in Beijing about this?
Oh, thank you a lot for your opinion. So I agree that for the deep-seated and small brainstem coronus malformation with no symptoms, that there is no surgery indications. But sometimes when the CM rebleed for more than 2 times and rebleeding, or sometimes the brainstem coronus malformation is just near the important nucleus, for example, the facial nucleus, and sometimes in the medulla. The rebleeding can cause the unconsciousness and the damage of the difficult to breathe. So in that times, the patient's lifestyle can be damaged. So in this situation with the surgery indications, even though it is very difficult to do the surgery or deep-seated, that we will need to do the surgery as soon as possible. So in our hospital in Shanghai, Huashan Hospital, that is our surgery indication. There are 4 indications. The first is it is very large and very easy to find. That kind, even though there is no symptoms, we can do the surgery, because the MRIs after the surgery and prognosis is very good. The second is the rebleeding. When it rebleeds for more than 2 times. And the third is that even though the CM is very deep-seated, but there is a safe entry. There is a safe entry zone to reach the CM, and the patient is very eager to do the surgery. The fourth is that when it bleed near the, for example, the medulla and some very important nucleus. So at that time, we will do the surgery. But now there is also some clinical experiments of use different drugs to help us to stop the CM from rebleeding, but it is still under experiments. So thank you.
Yeah, I completely agree with that, and I like your approach. It's not one size fits all. We have a carcinoma and it has a 1 or 2% bleeding chance per year and that kind of thinking. So you really have to look at it a little bit in a more discriminatory way when it comes to these lesions. So thank you for clarifying that point. Thank you.
Thank you for your opinion.
Okay, thank you, Doc. We have another statement from a neurosurgeon in Afghanistan, Mutawaki Zahir. He just mentioned about using steroids. Do you use steroids in the operations you discussed? I think that was his question. Is that the question, Mutawaki? You want to know if steroids are being used? Unfortunately, we can't communicate here just by text. Can you comment on that, Dr. Yang? I'm trying to figure out if it's a question. He just wrote steroids in neurosurgery. Maybe he's not really writing specifically to what you talked about. Okay, and he's not answering about what, Mutawaki, just text what your question is. I don't see your, there are 3 benefits of steroids, or is that kind of off the topic, Dr. Yang? Can you comment on steroids, using steroids in the surgery, or is that off topic? You're muted, Doc. You're muted. We can't hear you. Can't hear you.
Can you hear me now? Yeah. So,
yeah, I hear now.
So about the use of the steroid, in our hospital, most surgeries we will use the steroid. Most of the time we use the dexamethasone. So most of the times we use 5 mg we used it to help us to decrease the inflammation. So sometimes in the surgery of the neurocerebral vascular, we use maybe 10 mg the dexamethasone to help to. We found that when we used the steroid during the surgery, the cerebral can be a little bit tough or hard, then we do not use it. So it can help us to not damage the brainstem or the cerebral or the brain. So I'm not quite so sure this question is for me or for the first topic.
It's hard for me to say. He just wrote it in the chat, so I'm trying to put some context into it, and unfortunately he's not answering. Okay, Wan Li, you think we should wrap up?
I'm here. Yes. Okay. So yes, thank you for Dr. Nanda and Dr. Yang's talk. Yeah, both very interesting. Focus on the clinical treatment for the some difficult cases. Yeah. So yeah, hope everyone will enjoy that. Thank you.
Yes,
Thank you, John,
yes.
for your organization.
Yeah, thanks, Wan Lee and Dr. Yang, thank you. Very excellent presentation. And that ends, see you later. Thanks, Dr. Yang.
Thank you.
Okay, now the didactic portion of the presentation is over. And now we're kind of changing things, Sri and Wan Lee. We're trying to get advertisers involved in the webcast because advertising is changing. Zoom is changing advertising, and we're trying to bring vendors in to help support education because we're finding that if we can provide support for education, that companies will sponsor conferences. So we want to bring them into the advertisers into the digital age. And with that in mind, and you're welcome to stay, but this is not part of the didactic presentation. And I'd like to introduce the head of SanMas, Ram Kumar. He's going to introduce himself and give a little demo and perhaps field a few questions. Hello, Ram. Are you there, Ram?
Hi. Hi, Dr. John, and hello to all panelists and so greetings from Sanma, and I am Ram Kumar. Hi, hello everyone. So I wish to share my one of my product video. So here we go. Can you view my screen, everyone? Dr. John? Can you view my screen?
Yeah, unfortunately, it's a poor internet connection, Ram. Go ahead, try it again.
Hello.
Yes, we can hear you.
Oh, okay. Okay. Then just allow me.
Yeah, the video's not playing. Not playing. Want to try it again?
Yeah. So what my screen?
Or you can load it up again, Ram.
Can you view my screen?
Yeah, it's not that usually means your internet connection is not too good.
Yeah.
So
Yeah.
yeah, okay. I think we're gonna have to cancel this, Ram. That's okay. That's okay. We'll improve, and part of improvement is preparation, getting ready to present, and have
Yeah.
a
Yes,
good.
doctor.
Yeah, it's not working, Ram. Can you try it again? Do you want to try it again? Do you want to try to load that video up?
Yeah. No, there is some issue in my system. So
Okay, I'll tell you what, Ram. Why don't you forget the video. Forget the video. Okay. Okay. And I'd like to. Can you talk about your company?
Yes, second.
Can you talk about your company?
Can you view myself?
Yeah, I'm gonna stop your sharing of the screen.
Okay. Yeah. So we are physical operating groups for neuro, spine, and plastic surgery, ENT, ophthalmology. So we have a wide range of models and variants for all specifications. And we do have developed exoscope. So which is having a
Ram, excuse me, Ram, we're gonna have to stop.
Enjoy the every time we start and with their hands things and all. So these are two products we developed in other parts of our country. We are getting more. Yeah.
Okay. Okay, I'm not getting much out of this. Can you hear that, Martin, at all?
Yeah. Can you hear me?
Not really, Ram. Your
Hello?
internet connection,
Hello, Dr. John?
Yeah, your internet
Interruptions,
connection,
yeah.
it's not working, Ram.
Yeah.
Yeah, unfortunately, the video is not playing. So
Yeah.
I think we're gonna have to end this now. It's not working. We'll get prepared better the next time.
Okay.
So, okay, don't worry. We'll get this sooner or later. I think it's the technology
Sure.
that's going to work to allow you to show products, because we have to
Okay.
find support for our video webinars. And next time we'll prepare before the webcast. Okay, we'll
Sure.
rehearse. We'll rehearse, okay, Ram?
Please, yeah.
Okay, thanks
I'll
everybody.
just
Go ahead, Ram.
I'll just type my email ID for queries.
Do you want to give a presentation or something else?
No. I'll share my email ID for any queries.
Okay,
Yeah,
very good. Very good. You put that in the chat, your email
Yeah.
and your, okay, everyone watching, Sri,
Yeah.
including you,
Yeah.
there's an email address of Ram if you want to see the products of his company,
So I
Sandma.
can share my inputs.
Yeah, he'll be able to share his direction, a URL to the video, company information. And the next webcast, we'll have Ram back on. We're gonna bust out.
Thank you.
We're gonna have a great presentation. Okay, Ram, thank you very much.
Yeah, bye.
And thanks for coming, everybody. Thanks, Shrey. Great. Martin, thank you. Oh, Martin, you wanna?
You're welcome. You're welcome. I didn't
Martin.
use any Chinese. You know, this doctor is actually, her name is not Yang. Her name is Yang Zhixiao. But anyhow, yeah.
Oh, you speak Chinese.
I have been Yang Zhixiao.
Listen,
I think that's how you would say it.
Martin, you're in Dubai now, right? Or are you in Switzerland?
Yes, I am. I had a lot of other things to do, so I was kind of missing a lot of webinars, and I'm struggling here with this new computer. But anyhow, yes, I will be participating a little bit more again, and
listen,
hopefully, yeah, say.
Well, do you feel like presenting? Have you presented yet or no?
I presented something rather simple about some drilling techniques in the spine, and I think that is important. You know, I mean, all of this high-end stuff is also important for people to know. But you know, how many cases are you going to get? The ordinary neurosurgeon, his bread and butter business is not going to be brainstem cavernomas and that type of thing. But yeah,
okay.
Sure.
Do you want to present in 2 weeks?
Yeah.
Well, think about
Okay,
it.
well,
Think about
I'll
it.
think about it. Yeah, because I'm kind of busy right now doing all sorts of things. And
Yeah.
yes, I will participate again and
Yes,
contribute some.
Please
Yes.
put your email in the.
Yes, sure.
Okay, Martin. Thank you, Sri.
Okay,
I'd
take
like you
care.
to meet. I'd like you to meet Martin. And before you go, Martin, Sri, you there?
Who is this?
This is a neurosurgeon. This is Martin, Sri. Unmute. He's a neurosurgeon from Switzerland. He's in Dubai
Hi.
now.
Yes.
Hi.
Okay, now
Hi.
Sri is a neurosurgeon from Myanmar.
Yeah.
Now
She doesn't
now-
look Chinese at all. She looks
I-
Southeast Asian. Yes.
I know, yeah. She's in Japan now, trying to work out her future in neurosurgery.
Yeah. Well, I'm being told the Japanese actually, even though, you know, politically and historically it hasn't been easy for China and Japan and so on, but they were the first ones that went to Beijing and kind of started up modern microsurgery there.
Yes.
Yeah. So I hope they're teaching you something. They're not just saying hi. Yeah. I hope they're really
Okay.
teaching you something. They're quite funny, aren't they? Saying
Yes,
hi.
yes. I'll be looking forward.
Hi.
Yes.
Okay. Nice talking
Thank
to
you.
you. Talk to you. Okay. Bye.
Okay, very good. Okay, very good. Wan Lee, thank you very much. And okay, we'll talk later, Shri, okay? And Martin, thank you very much for participating. Bye-bye.
Yes. Bye bye.
You're most welcome. 再见, Yuan Li.